Welcome to NephroTube online nephrology lecture. This lecture is about hypocalcemia. We discussed in previous lectures hyponatremia, hypernatremia, hyperkalemia, and hypokalemia. All our lectures are recorded and uploaded on our YouTube channel, NephroTube, and the PowerPoint presentation is available at nephrotube.com. Starting by a small introduction about normal calcium homeostasis. Calcium is mainly present and located in bone. 99% of the total body calcium is located in bone. A small amount of calcium is present in plasma, interstitial fluid, and intracellular fluid. But although the amount of calcium is low in the plasma and intracellular fluid, it is critically important, especially for the normal neuromuscular excitability and activity, for the normal blood hemostasis. Normally, the calcium is present in two forms. The first form, in the bounded shape, calcium is bound to plasma protein mainly or primarily albumin. And there is a free ionized calcium, which is the physiologically active calcium, which is important for the normal homeostatic regulation for the muscle activity and nervous activity. The calcium bounded to albumin is inactive inert calcium. So total serum calcium, we have two forms of calcium. The first is total serum calcium, which is the bounded plus unbounded free ionized calcium. We can measure the total serum calcium, which is normally in the range between 8.5 to 10.5 milligram per deciliter. And we can measure only the free ionized calcium, which may be more accurate in the diagnosis of cases of hypokalemia. And as calcium is related to the serum albumin level, it is important to make a correction for the serum calcium if the patient has hypoalbuminemia. If the patient has hypoalbuminemia, you have to subtract the patient's serum albumin from the normal serum albumin, which is about 4. Then multiply this by 0.8, then add this to the measured serum calcium of the lab. This will give you the corrected serum calcium, total serum calcium for the patient. Back to the normal physiological homeostasis and regulation of serum calcium in the body. 4 factors may affect the serum calcium. The first is PTH, the second is vitamin D, the third is the calcitonin hormone, and finally the FGF23. Starting by the PTH hormone, parathyroid hormone is secreted from the parathyroid glands. Parathyroid hormone increases the resorption of the bone, and its effect only on the bone will increase, theoretically will increase the serum calcium and serum phosphate. But at the same time, parathyroid hormone acts on the kidney, which will cause increased calcium reabsorption and has a phosphatiuric action, which will increase phosphatic secretion. So the end result of the PTH hormone, after the combined effect on bone and kidney, will be increase in the serum calcium and decrease in the serum phosphate. So finally, the PTH action in the body is increased serum calcium and decrease in serum phosphate. So the stimulus for the release is the parathyroid hormone if there is low serum calcium or if there is high serum phosphate level. Also, vitamin D affects the calcium homeostasis. The calcidiol is formed by the liver in the kidney under the action of alpha-1 hydroxylase enzyme by the assistance of PTH hormone. The calcidiol will be converted into 125 vitamin D, which is the active form calcitriol, which will act on the intestine and increase calcium and phosphate reabsorption. So the final action of the vitamin D is increase in both serum calcium and phosphate. So the main stimulus of the vitamin D formation is the decrease in serum calcium or serum phosphate. So there is a balance and flux in both ways between the extracellular fluid and the plasma, with the bone, kidney, and gastrointestinal system, plus the soft tissue and intracellular calcium. All of these targeting to maintain the normal serum calcium level. The third factor that may affect the serum calcium level is the FGF23, the fibroblast growth factor 23. Actually, it is important for us as it increases in the cases of chronic kidney disease. But generally, FGF23 decrease the activity of vitamin D, decrease the formation of calcitriol, and also it has a phosphatiuric action as it increases the phosphate reabsorption and increases phosphate excretion in the urine. Finally, the calcitonin hormone is secreted from the parafollicular cells of the thyroid gland, which cause decrease in serum calcium level. So finally, all these factors act at the same time in a balance to maintain normal calcium homeostasis and normal serum calcium level. Go to our main topic today, which is hypocalcemia. We'll cover the clinical presentation of hypocalcemia, diagnostic approach, and treatment stepwise approach. Regarding clinical presentation, as most of the electrolytes, the onset of the disease is an important factor which will affect the severity of the symptoms. Usually, acute disturbance of any electrolytes will have more severe symptoms, while the chronic change in the electrolytes will have less severe symptoms. The main effect of calcium deficiency is related to the normal response or the normal effect of the calcium on the neuromuscular activity. Normally, the calcium level may affect the excitability of the nerve and muscles. In case of hypocalcemia, when there is low extracellular calcium level, the excitability of nerves and muscles increases. This is because calcium level affects the voltage response of the sodium channels. In cases of hypocalcemia, the sodium voltage channels response will be faster with more rapid influx of more rapid influx of sodium from the extracellular space to the intracellular space with rapid, fast depolarization and increased excitability. So you'll find most of the hypocalcemia manifestations are in the form of spasm of the muscles, seizures, and muscle twitches, paresthesia. So if you look at these clinical manifestations, if there is acute hypocalcemia, we'll find a neuromuscular irritability in the form of tetany, paresthesia, muscle twitching, carpopedal spasm, seizures, laryngospasm, bronchospasm in the severe cases, and you can make the Tourette sign and Gawad sign that I will mention now. In the heart, in the ECG, you will find prolonged QT interval, and this is a danger sign that will require intravenous calcium, as we will mention later. There may be hypotension, heart failure, arrhythmia, and finally papilledema. The Tourette sign is done by elevation of the blood pressure pump over the systole of the patient for 3 minutes. This will induce ischemia for the arm of the patient. Ischemia in general increase the excitability of the nerve. In normal population without hypocalcemia, this ischemia will cause ischemic pain, but in patients with hypocalcemia, as their nerves have a hyper excitability due to hypocalcemia, then when we induce ischemia on top of hypocalcemia, this will increase excitability more, causing carpopedal spasm, as you see, with flexion of most of the joints of the hand and extension of the interphalangeal joints. Also, to induce the hyperexcitability of the hypocalcemia in this patient, we can make the Gawad sign by tapping of the facial nerve along its course. This will cause ipsilateral contraction of the facial muscles on the same side where you tapped. This also due to increased hyperexcitability of the nerve and increased response of the nerve. In case of chronic hypocalcemia, you may find basal ganglia calcification, extrapyramidal signs, Parkinsonism, dementia. All are central manifestations. Also, there may be cataracts and finally dry skin. This is regarding clinical presentation. So hypocalcemia mainly may be presented by neuromuscular irritability, ECG changes, or it may be discovered accidentally through routine lab investigation of the patient. So what is a diagnostic approach for case of hypocalcemia? First of all, as we always mention in all electrolyte disturbances, we have to exclude drugs that may cause hypocalcemia. And most of these drugs we we use them as we are adult nephrologists. For example, cinacalcet, which we use in the management of tertiary hyperparathyroidism in chronic kidney disease patients. Other drugs that may cause hypocalcemia, bisphosphonates and denosumab, calcium chelators, and etc. Also, I must comment on gadolinium-based contrast agent. Gadolinium-based contrast agent gives factitious hypocalcemia or true hypocalcemia because the gadolinium itself interferes with the laboratory measurement of total calcium, giving untrue hypocalcemia in the lab results. So if there is no hypocalcemia, if there is no drugs that causes hypocalcemia, what is the diagnostic approach? This approach covers all the etiologies of hypocalcemia that we see as adult nephrologists, and also etiologies that the pediatrician may see, as rickets with its different types, vitamin D resistant rickets, hereditary vitamin D resistant rickets. But I will concentrate more on the etiologies that we meet as adult nephrologists. The patient has hypocalcemia, first of all, if it is ionized calcium, so the hypocalcemia is true. If it is total calcium, you have to check first the serum albumin level, because if there is hypoalbuminemia, you have to correct serum calcium. Then you have to check GFR, serum phosphate, magnesium, and PTH. If there is renal failure, so mainly the cause of hypocalcemia is renal failure. But actually, patients with chronic kidney disease may have other etiology for hypocalcemia rather than the renal failure itself. But you can't diagnose that except after trying of the treatment of hypocalcemia in your CKD patient. And if it is resistant for your traditional management, you may try to find another cause for the hypocalcemia in your CKD patients. Okay, also you have to check serum magnesium level. If it is low or high, you have to find the cause of hypomagnesemia and the hypermagnesemia to correct. As we will discuss later in the lecture of magnesium and its disorders, we'll mention that all of the disturbance of magnesium may affect other electrolytes, causing hyper or hypoelectrolyte disturbance. So it is better always to check the serum magnesium level, whatever the electrolyte disturbances that you have. If the patient has low PTH, so the patient has hypoparathyroidism, you have again to check the magnesium level, because magnesium level affects PTH level and parathyroid function. Or if you are a pediatrician, you have to check the family history and the genetic abnormalities for the rare genetic disorders. Or you have to check the history of the patient if there is surgery, radiation for the neck. And actually, we will not meet these cases as adult nephrologists. If the patient has high PTH and high phosphate, this is what is called pseudo-hypoparathyroidism. If low phosphate and normal phosphate, you have to check alkaline phosphatase and native vitamin D. If the patient has low native vitamin D with high alkaline phosphatase, it is osteomalacia or rickets. If there is low vitamin D with normal alkaline phosphatase, if there's vitamin D deficiency or malabsorption. And finally, if high alkaline phosphatase and normal native vitamin D, it is vitamin D resistant rickets. So I think that the approach is easier than those of hyponatremia, hypokalemia, and the hypernatremia. In short, for us as an adult nephrologist, a patient with hypocalcemia, we have to check the serum phosphate, magnesium, PTH, and native vitamin D, plus or minus alkaline phosphatase. This may take you to diagnose the etiology. An important point that hypocalcemia may occur with other disorders with critical illnesses. We, as a nephrologist, see hypocalcemia with rhabdomyolysis and with tumor lysis syndrome. And we discussed before, both in the lectures of acute kidney injury that are uploaded on the NephroTube channel. So these are factors which will be associated with hypocalcemia, and we discussed there when to treat hypocalcemia in these disorders. This is very important because, as we mentioned, the rebound hypercalcemia is very common in rhabdomyolysis and tumor lysis syndrome. So please check the lectures that we discussed before. Also, hypocalcemia may present with pancreatitis, severe pain, sepsis, and acute respiratory alkalosis. So always put these in mind. Then, what is the treatment stepwise approach of this patient? This is the final shape of the treatment approach. Let us take it step by step. First, for a patient with hypocalcemia without chronic kidney disease, withoght CKD-MPD, and even if the patient has CKD-MPD, you may follow these steps in emergencies of hypocalcemia. If there is severe hypocalcemia in this patient. First, you have to ask yourself, as we always do in all electrolyte disturbances, is there any acute sign or symptom as carbopetal spasm, tetany, seizures, or prolonged QT interval? If yes, the patient must have intravenous calcium. How to give intravenous calcium? Intravenous calcium initially given in the form of 1 to 2 gram of calcium gluconate in 50 ml of dextrose or normal saline, and it must be infused over 10 to 20 minutes. You may repeat it every 10 to 60 minutes if symptoms not resolved. Even you may give the patient an infusion of calcium in cases of persistent hypocalcemia, not only polysis, as in cases of hypoparathyroidism and pancreatitis. How to prepare the calcium for infusion in these patients? You have to give an intravenous solution containing 1 milligram per milli of elemental calcium. This is prepared by adding 11 grams of calcium gluconate to normal saline or dextrose in the form of, to give a final volume of 1 liter. This will give you a liter which containing 1 milligram of elemental calcium per milli of your fluid. And you have to give it in the infusion rate of 50 ml per hour at the initial infusion, and adjust the infusion according to the response of your patients. Then you have to measure the calcium initially every 4 to 6 hours. Also, if you are correcting magnesium deficiency in this patient, you have to follow up and correct any other electrolyte disturbance associated with hypocalcemia as if there is potassium disturbance. Actually, intravenous calcium give a relief of symptoms, and we have to switch to oral calcium and vitamin D if needed according to the vitamin D level of the patient once the symptoms are stabilized. What if the patient from the start doesn't have any of the acute symptoms? If the patient is asymptomatic, or if there is mild symptoms as paresthesia. If this, so what is the calcium level of the patient? As we mentioned before, it's better to depend on the analyzed serum calcium level. But if your lab doesn't make the free ionized calcium level, so you have to correct the total calcium level for the serum albumin. Don't forget that. So ionized calcium remains the gold standard for assessing calcium status. If the total calcium is measured, it should be corrected for any abnormalities in serum albumin. If the serum calcium level, the total serum calcium level is below than 7.5, or the ionized is below than or 3, then you have to give intravenous calcium. But if it is more than 7.5 milligram per deciliter as a total, or more than 3 milligram per deciliter of ionized calcium, if the patient is able to take and absorb oral calcium supplement, we have to ask ourselves, can the patient take oral supplements or not? And by the way, from the start, if the patient has no severe symptoms, or there is a signs of mild hypocalcemia as paresthesia, you have also to ask yourself, can the patient take oral calcium or not? If the patient cannot take oral calcium, whatever the cause, you have to give intravenous calcium. If the patient can take oral calcium, you have to give oral calcium and vitamin D if needed, according to the level of the vitamin D of the patient. Initially, to give oral calcium in the dose of 1.5 to 2 grams of elemental calcium in divided doses. And by the way, it must be given away with the meal on empty stomach, away from other medications, especially iron, to increase the bioavailability and absorption of the calcium. In addition to calcium, as we said, if patients with vitamin D deficiency or hypoparathyroidism, they may require vitamin D supplementation. Then you have to follow up your calcium level. If it is acute, you have to repeat serum calcium level every 24 hours. and if it is chronic, you have to repeat the calcium level after 1 week. If the serum calcium level rises and there is resolution of the paresthesia and symptoms, if yes, continue your supplementation and monitor calcium. If no, increase the oral calcium supplementation and measure again the serum magnesium level. It may be still low and need correction. If no improvement, you have to switch to intravenous calcium infusion. So this is a stepwise approach for the patient. If we want to summarize, when we will give the patient intravenous calcium, what is the indications of intravenous calcium infusion in patient with hypocalcemia? This will be if there is severe symptoms, severe acute symptoms or sign at the presentation. If the patient's serum calcium level is below 7.5 as a total or below than 3 milligram per deciliter as analyzed, whatever the symptoms of the patient. If the patient cannot take oral calcium supplements or absorb oral calcium supplements, whatever the etiology and symptoms of the patient. And finally, if there is no improvement of the calcium level after trial of oral calcium supplementation. So these are the indications of intravenous calcium in patients with hypocalcemia. I hope that the lecture was clear enough with a fine stepwise approach for diagnosis and management. Thank you and see you in the next lecture. Bye-bye.